Hi, I'm Brad Power. I'm the host of the Linnea Olson Hackathon, and today is a special session. This is the culmination of 3 months of sessions. I think we started in early April. I think this is number 15 or 16. So we've been getting to know Linnea, her situation, her treatment options, her testing. We've been through a number of things, and this is kind of crunch time. This is kind of the culmination of a lot of work that we've been doing over these past 3 months. Um, I hope that we can keep this to an hour. We're being respectful of all of your time, obviously less if we can, but more if necessary, but hopefully try to keep it under an hour. Um, this is really to refine, the objective of this meeting is to refine the document that we would deliver, much like the document that we pulled together on tissue management, which was delivered to Jess Lynn and Alice Shaw. That we would pull together whatever our advice is, our report, our thoughts that would guide Linnea in this moment when she is not responding well in general, and it seems that the current clinical trial that she's on, the SHP2 inhibitor, is probably not going to work, and she'll be leaving that. So it's the classic question of what's her best next treatment. For those of you who are on Friday, I think we can cover this quickly, or you saw it in the notes. Kimry has generously given her views, which creates a baseline for us to talk from. Many of you were in that, but I would ask, I think, to just sort of set the stage, kind of set the floor, ask Kimry to just remind everyone. So it just gives us a starting point. And Kimry has a brilliant thought process about sort of categorizing the kinds of things we can do in the time frame that we have. And what's reasonable given her physicians are likely to be fairly conservative. And so it's like, given all the reality that we are intimately aware of with Linnea's situation, what is the best next treatment? So, and how to think about it, like categories of things and combinations and that. And then Allie has spent some time, again, we talked about some of this on Friday, but Allie has prepared a report as well. So those will kind of give us the feed stock, and then we'll have a discussion, I think. Others can weigh in. I'm glad to see Lars is here. Who's a medical expert, Emily, Ricardo, who know the ALK arena, Will, who's an MD. So we've got a lot of great brains in this collective right here. So we can, I think if we can go Kimry, then Allie, and then kind of open it up and see what else anyone else has to say. Is that okay, Kimry?
Sure, sure.
Thank you.
I don't have anything formally prepared, and I don't want to be too redundant for the sake of those who heard me pontificate on on Friday's call. And I'll lastly say I've actually been working all day, so I'm a little bit like fried at the moment. So pardon me if I'm just a little tired, but yeah. So I think given the situation that, as far as we know, the truth is we really don't know too much about Linnea's medical status at the moment. We're I guess making some presumptions. Is that correct, Brad, about whether she is now out of the SHP2 inhibitor trial? I guess we're just sort of guessing that might be the case, right?
That's right. Guessing, don't know. Guessing, don't know. I'm very naive. I'm not a medical expert, but I'm assuming that given her current physical state, that would indicate that this treatment is not working, and so she'll either resign or be kicked off. But I have no experience with this, so I'm just guessing.
So I guess from that perspective, then I guess even if she hasn't officially by scan or by RECIST criteria progressed, that it looks as though she's clinically progressing in terms of symptoms, et cetera. So because of that, that has implications about her performance status and whether or not she's even a candidate for a next clinical trial. So kind of to back up, Brad has sort of alluded to categories of, next things to consider, and I kind of put them into 4 buckets, I guess. And one is another clinical trial. The other is the chemotherapy, immunotherapy, either alone or in combination idea. So these are approved therapies. There's compassionate use of experimental therapies, and then there's off-label use of existing other therapies that aren't necessarily targeting specific mutations that were found in Linnea's report, or off therapy in terms of there not even being oncology agents. So if we set that framework of those kind of 4 buckets, and we assume based on Linnea's current physical status that she's probably not a candidate for a clinical trial, that takes a big, huge chunk of options kind of off the list. And so if we think then, okay, there's been some thinking about chemotherapy and or immunotherapy, and the way I guess and again, I'm not an MD, but the way I think about that is from her CARIS report, maybe I should just summarize that as well for those who didn't look at the CARIS report or anything on the Slack channel, but she still has an ALK mutation. It's in the, I keep forgetting is it G12RO, the resistance mutation for leratinib. She has a KEAP1 mutation, which is sort of a new finding for this group. She is PD-L1 negative by all 3 antibodies tested, and by negative I mean a 0 score, which again, we all know PD-L1 is not the best biomarker on the planet. And she's also tumor mutation burden low, and microsatellite stable. There was also MYC amplification found, and P10 by IHC was a 1+ IHC score. So that's
sorry to interrupt, Kimmery, but Linnea is just, I think Evelyn is Linnea, and so I think Linnea has just joined us with audio. So
great.
Linnea, so glad that you could join us. Thank you for doing that. We're just going to run through about an hour here to come up with your best next treatment option.
Okay, and I would join with video if I could figure out how.
No worries.
Okay.
So anyway, Kimmery was just summarizing the conversation we had on Friday and sort of the state of play. So if at any point you want to clarify, question, or challenge the state of play, or Kimmery, if you have questions for Linnea since she's on,
I have lots of questions, and I want to interrupt myself and shut up and want to hear from Linnea, especially with regard to, I think you were scheduled to have a scan last Thursday. Did that happen?
I've just had chest x-rays recently, and maybe I'm going to get on the meeting here, but I will have a scan again this coming Thursday.
So when you say,
all right.
So by scan, do you mean a chest x-ray, or I guess we're thinking about your clinical trial, the SHP2 inhibitor trial? Is my understanding you were scheduled to have your first on-trial CT scan last Thursday.
Sorry, I gotta leave the meeting on my phone. Okay, I think it's just this meeting now.
Yes.
All right, sorry, Kimmery, go ahead.
So we're wondering about the status of the clinical trial that you're on.
Yeah, the trial that I'm on, the thinking at this point is to continue to hold drug because it may in fact have contributed to the pleural effusion. And maybe even more importantly, we still cannot assess what's happening with my cancer because there's still too much infection and too much fluid from the effusion in there to see it. And I spoke to Alice today, and she's going to try this week to have a radiologist who's always looked at my scans to look at them again and see if he can ascertain anything. But either way, I will have a scan next Thursday and also a Pleurex cath installed. And I'm sure they will scan before it's installed, but I wonder if they will scan afterwards too, if they're able to pull enough fluid off.
Okay. And so you're off of the experimental drug from that trial.
I am. So
But
I'm
you're
just
still-
on lorlatinib right now.
But you're still on the protocol.
I must be, because they have me scheduled for a brain MRI tomorrow, which makes no sense. I need to contact them in the morning. I can't imagine why I'd need one right now.
Okay. So I don't know where we should go next in the discussion. I guess I was in the middle of talking about yeah, your Keras results, Linnea. I was just summarizing those for the group.
Which are very helpful, because it shows a mutation that I retain that I had before, but also a brand new one.
Yeah, the keep one.
Yeah.
And so, and then we were also discussing, Linnea, whether or not, given your current physical condition, whether or not you would still be a candidate for a next clinical trial in terms of, you know, how you're feeling physically, and whether you would meet the inclusion or exclusion criteria of a next clinical trial. So,
Right.
that's
Last week, I definitely would not have. I was really, really sick, but I'm encouraged because yesterday my temperature came down, and it rose a little bit again last night, but you know, I'm staying out of the 101s. So I feel so much better too.
You sound better. You sound great, by the way.
Thank you. Thank you.
She's a
Hey,
good.
Lynn, quick question for you. Did Lynn or did Alice comment on the keep one?
No, well, only, and I'm not sure. I have not looked closely enough at the Keras report myself, but what Jess talked about was that, for instance, TPX, who is offering the potential for compassionate use, she said that none of their clinical studies have been with this combination of mutations. And I don't think I realized before that how they were combined made such a difference as far as how you might respond. But Jess called the company TPX and has been talking to someone there, and their feeling is that there's good reason to believe I might respond. So Jess at this point feels that it's good and proper that TPX made this offer, but she also said to me, it may not be an offer you want to take. So I think
Because of the toxicity, or because of uncertainty or no data?
now just, well, there is some toxicity with it. I remember when this molecule was first developed, Alice telling me it was a dirty molecule, you know, that there was the potential for a lot of side effects. And clearly that's something they want to try to avoid in my case. But the other thing that Jess mentioned is we may not want to, even if we decide to do it now, because it might not be a therapeutic dose. And so ultimately what may happen when we can actually assess what's going on with my cancer is that I may have to return to chemo for a short time, just as maintenance. And my experience with chemotherapy is I've never responded, but it has at various junctures kept my situation stable. And certainly we don't want it getting worse.
So Linnea, following up on Ricardo's question, the KEAP1 mutation, there is, Calithera has a glutaminase inhibitor, and they do have a expanded access program. It might be interesting to have a discussion with your physicians about whether that's an option to tie you over.
Right.
That would, sort of indirectly, work through the KEAP1 mutation. The KEAP1 mutation has an implication for that product to work potentially.
Now, Kimmery, I spoke to Jess about you and this trial. What do I need to do to make it okay for you guys to potentially talk to each other? Is there anything?
That's why I sent you the HIPAA authorization.
Okay, I'm sorry. I was not in the office last week.
I sent it to her too.
Okay.
Assuming I have her correct email, but I didn't hear back from her because she's not going to talk to me unless you give her permission.
All right, I'll do that because that would be great.
None of us can talk to any of your physicians or to Karis without your written permission.
Linnea, this is one of the most important things that we've learned through this whole process. Is important because this is before an HOA, I'm sorry, HPA or healthcare proxy even kicks in, and I think that folks here were a little bit stuck because they couldn't communicate, and so this is probably one of the most important things in terms of communicating and be on because this all was on real time. So,
yeah, and what happens when things change suddenly and the patient gets very sick, like just happened. So yeah, no, that's all important stuff. And I mean, my attitude toward all of it, I'd give you all access, but I guess you have to go through the proper steps.
Right.
Yeah, I think there's two things: access to be representing you, like for Kimmery to talk to Jess or Alice or etc. And there's a second one is just access to some of the portals and exams that you have and all that. But anyway.
Right, and I would give open access on all accounts. I wish there were a way to just sort of check a box and say we're good here, but I know that's not how it is.
So Linnea, if you do have the energy, if you go back to that email that I sent you, print out that PDF. I filled in all the blanks about.
Yeah, I saw that.
So if you just sign that and give it to Mass General, then that would allow us to. The other thing is getting through their phone system. That's that's probably a bigger hurdle.
And having just spent a week in the hospital, I had a long conversation with Alice today about how even the hospital is like a completely different entity than the clinic.
Yep.
Hey,
Linnea, did you talk to Jess about participating in this hackathon, like coming in at all, or that was something that she?
Yeah, I asked her about tonight, and she demurred. So, I think she has begun to embrace some of what is happening here more than I thought she would. But the siloing that we spoke about initially, it exists, and this whole thing represents sort of a free range approach. But I can assure you that she very much appreciates some of the additional information that has come in. Yeah, but like Ross's response to KEAP, I think oncologists kind of feel like they're driving this ship. So
yeah, I think that Ross is obviously like Alice, like at that level. So his input and the fact that he watched the videos and responded, I mean, that's like
huge.
amazing. Yeah.
It's huge. Yeah.
I would just say, Linnea, just underscore what Ricardo was saying. What I realized is I know that you're very open about your data. We've also talked about, the decisions that are being taken on tissue And if Kimmery could have been talking to the pathologists at MGH, you know, some of these, like the mishandoff to M-probe or what have you, could have been solved.
Right.
And then the third category is care proxy. And Grace Cordovano was very strong on this idea. You need someone who can stand in for you if you're incapacitated for those decisions in crunch time.
Right.
And so,
And I do have my friend Melinda as healthcare proxy, and
Right.
she was trained as a hospital administrator, so none of this is foreign to her. But I kind of feel like the tissue thing that just quickly got out of my control, you know, where it felt like such a victory to be able to say, this is what I want. But then I didn't have a lot of control over where it went and how much went. But I think an honest effort was made. And in the end, it's more that that the blocks that they got were, it's like a marbleized steak, you know, they weren't fully populated with cancerous cells.
Mhm.
So only a certain part of it was useful.
that's what you call cellularity, Kimmery?
Yeah, that's always, it's always, it's part of the problem. You know,
Well, Linnea, I don't know if we have to solve it now, but selfishly for the purposes of the hackathon, if you can't be here, if you could have someone like Ricardo even, you know, to sort of step in your stead and sort of play you. And then from the perspective of just the general integration, like with Melinda hasn't been part of this. And so,
right. And I haven't even told her that
Yeah.
I want her to be part of it, but I'm going to be seeing her tomorrow, so I can tell her then.
yeah, and the same thing with Jess Lynn. It's like what we realized in this crisis situation is that we were ill-equipped, unequipped to deal in the heat of the moment with these things because we didn't have Melinda to fall back on, we didn't have Jess Lynn to fall back on, we couldn't talk to them, we couldn't, you know, it's like we were just very conscious of the fact that you were the gatekeeper to all of that. And then when you drop off, the whole thing comes kind of crashing down.
And I was honestly too sick to care, you know. It was like I was just trying to keep this horse going. So
So the lesson, though, as I think Ricardo was pointing out, is for the future to prepare for this eventuality and have those you know, backup plans that you can invoke in the moment.
yep.
Okay.
yeah, 'cause it's all about taking burden off of you, Linnea, and trying to keep things moving, even though I mean, you shouldn't have to be worried about those things when you're trying to take care of yourself.
I think the two things that were important are definitely the HIPAA thing in the interim, that you can have the personal representative. And the second thing is that point of contact, like that, I don't know if you said Evelyn or Melinda or whoever that is, that at least Brad to know who that person is, because we were just completely in the dark. So I think that that person that's kind of following you and knowing that it's kind of can connect to you while you're not even on the phone. I think that that I learned. I'm like, holy shit, this is like the person that is next to you, that caretaker is really important so that it all comes together and it's, you know, some communication there.
Right. And I think like my relationship with all of you is sort of separate from all these other aspects of my life. So it's not a place where anybody was gonna organically jump in, but maybe in future hackathons, it would make sense. I don't know if it was Grace or Kimmery who was, or somebody else who was talking about how I needed like this advocate, you know, and it's almost like somebody assigned to me as a caseworker who could handle this sort of stuff, and that obviously this information would be sort of gathered at intake instead of just relying on me, because I feel like last week I got incapacitated.
Right. Exactly right. Exactly right. Okay. So
And
that's.
can I just add on to that? I mean, that's something like, I think there were those of us who would be perfectly willing to jump in, Linnea, for you on that behalf, I myself being one of them. So just don't be shy.
Okay. And you know, it's the sort of thing where I think we just need to have it designated so nobody has any questions about it, you know?
Mhm. Agreed. Agreed. Okay, Kimry, is there anything else you need to know from Linnea, and how would you reformulate your, your logic, in this current situation, and or like, even should we postpone this conversation, or should we proceed and give Linnea the best advice we can on what she should do? It sounds like there's a set of bridging decisions to get, whether it's chemo or the Calathera, one of the Calathera drugs, and then the Turning Point clinical trial, which is available sometime in the fall, I guess.
Yeah.
There are also some approved targeted therapies that I'd like to talk about today.
Yeah,
Okay.
so I mean, with regard to the framework I was setting up, I mean, we were assuming clinical trials were, maybe off the table. Maybe they're not, but I still think that the inclusion exclusion criteria of those trials are really, we have to really do our homework on that. Some of them might exclude prior, ALK therapies, especially so many prior ALK therapies, et cetera. So I still think that clinical trials are probably, we should keep combing them and looking through them, but I don't know, I'm more on board with sort of compassionate use or off-label.
Exactly. Well, there's even on-label some.
Yeah. So, and really, I think, again, like I kind of opined on this, and again, I'm not a doctor, and I'm not even that much of a scientist these days, but I really think the keep one finding is very relevant. And I would,
Well, Jess didn't dismiss it. So,
Okay.
yeah.
Yeah, and there's not a lot known about it, and quite frankly, and I'll defer to Lars maybe on this one, if you've ever heard of a ALK and keep one co-mutation. I myself have not heard of that. So
I haven't done the search yet on CBioPortal. I was thinking of doing that right now. I am slightly familiar with the glutaminase inhibitor KEAP1 pathway NRF2 activation. In my experience, it wasn't, all KEAP1 mutant cell lines that we tested in the lab were sensitive to CD839. So there's some other, predictive biomarker that or maybe is out there, but it's not, 100% of the models are sensitive. So I'm interested to know if there's any clinical signs of activity with that trial, whether or not the chemotherapy arm is mandatory. I guess I'm also, sorry, I'm spitting out a bunch of ideas and thoughts here. I've been a little bit MIA over the past couple months, so this may have been already covered, but in terms of the ALK mutation, is the only identified ALK fusion G1202R, or are there still EML4 ALK wild type or other, clones present by NGS?
the Karas report only talked about the point mutation in the G12. So that's all I know.
So only G1202R, no detectable previous mutations, and there's no compound mutation there. I thought that the issue was that, or primarily was that it was a compound, a double mutant in cis, so that was what's causing the resistance to 1202R.
That wasn't reflected in the Karas report, but I don't know if there are prior reports where that may have been the case. I don't know.
I feel that's sort of how Jess characterized it. But Lars, as you're talking, I have this idea, and that is, even though we're not able to get Jess or Alice to be involved directly, they have both always been so good about answering questions. And were I better, I would be taking notes and going back to them. But maybe in lieu of that, we could have a place where people could submit questions that I could then take to them, because I think that's a format they would be comfortable with. And I then I could bring the answers back to you.
Yeah, part of me out in my personal assessment of my expertise compared to Alice Shaw's is that, if I have a question, I'm sure she's thought of it and would come up with, or would see a path forward in yeah, I don't know.
But sometimes the questions themselves are novel, things they may not have thought of.
Yeah, it's funny you say that, Lars, because I sometimes think of the opposite way is, clinicians, who may not have a lab that are doing basic biological research may not think of some of these things. And I would think that someone like yourself, who's done a lot of work in the lab, a lot of cell line stuff, and read a lot, probably more even than some of these physicians, would have some novel ideas. And to me, that's always been the missing piece of medicine is, if you're clinical practice focused and you work closely, even like Alice, I know works closely with all the drug companies that are developing these inhibitors, but you kind of know what comes through that channel and your own time that you have to read. And a lot of them don't have the leisure to read and dive deep into the biochemistry of this. I mean, why are we now learning about STK11 and KEEP, for goodness sake, and why it's clinically relevant? It's been there the whole time, right? So, to me, it's kind of like, I really think there's a greater role for basic scientists and all this. And that's just, I guess, me pontificating and nothing more, but.
No, Kimmery, you make a good point, because even when I went in there a week and a half ago, so sick, I knew that I had an infection. I knew that I had a pleural effusion, but these were things that until they could be shown on a CAT scan, nobody else was sure. It's like sometimes that other perspective is absolutely necessary.
I want to, I think, answer something Lars said, but I also want to give Allie some time. One of the questions Allie had, she was asking about some of these same questions you were talking about, Lars, about the mutations. And I went back and transcribed, Linnea, your reading of, I guess, your pathology reports in the second session where you did the medical review. And I'm looking at it here, I posted it in the Slack. It said on November 2018, biopsy showed in addition to G1202R, had G1269A and S1206F as mutations. So anyway, I pulled that because Allie was asking questions about that sort of information. Allie,
yeah, those are gone now.
Oh, those are gone now. Okay.
Yeah.
Just the G1202R is the only one left?
Well, and there's another one. There are two. And I'm not sure if it's the KEEP or what, but there is a second mutation.
Okay.
I was specifically asking about ALK alterations, and thank you so much for looking into it so thoroughly, Brad, because there was a slide that, Linnea, you took a picture of. There was like a laptop and your picture of a presentation that said ALK rearrangements and response to something. And that's what made me question, wait, did you have a specific rearrangement? And then in addition to that, this mutation in ALK, or just the point mutation is what we're looking at right now? That was my main sort of question. And the second one was, what were the previously given drugs that you took, that you were on?
So,
Yeah.
Ali, you pulled together a report, or you have, what's your kind of bottom line, given, well, I don't know, before we had this conversation or at this point, where's your thinking?
So I can just, if it's okay, I can quickly explain what that report is about. I shared it on Slack, but I can also, share my screen and just display it real quick, and then I'll try to be as succinct as possible, but also I want to make sure it's clear. So feel free to interrupt and ask me questions. So this is our report, and CureMatch reports only deal with approved therapies. So if we're going to discuss other things, that's when I kind of shift my hat from being CureMatch CSO to just being me, Ali, who is thinking about all the other biologically relevant things. But right now I'm just going to explain what we do, and this is our standard report. We take all of the alterations, and we did include TP53 as if it is still there, because it was in 2 previous reports. And when we have longitudinal data, we incorporate previous variants as well, because what we've seen in many of the studies is that the variant is almost never completely gone. It's just that subpopulation of the cancer is just very small. But as soon as, let's say, certain environmental pressure, like a new drug, makes it advantageous for that specific subclone of the cells to actually amplify, proliferate, then they will, that subpopulation starts to take over and come up. So you can't completely turn a blind eye to it, even if in the latest report, this alteration wasn't there. So TP53 is something that we considered. The rest we already talked about, it's been covered. And I guess with or without additional ALK mutations or rearrangement, one of the things that is very clear, and it's here to stay, it's that ALK is altered. It's not functioning normally. It's overly functional, and that's not going to change. That's the one thing that's been consistent. And unlike in other cancers where it's very hard to pinpoint a particular driver or initial driver, this is as much clarity as we can possibly get, is that it's an ALK-driven tumor. And just in our consensus opinion, besides what's in the report, it seems like it would be risky to not proceed with any kind of ALK targeting therapy. So in our therapy sections, it's basically a combination of targeting ALK together, or there's also monotherapies indirectly targeting TP53. Because we don't have an approved drug, that trial would not apply here to target KEAP1. This is listed here, but it says it's not actionable. This could factor into, maybe not suggesting chemotherapy or immunotherapy, and that's also based on other markers of the overall profile that we have. But we just focus on the targeted therapy here first and foremost. And sometimes we provide 3 combination, when it's applicable, we provide 3 drug combinations therapies and list them. In this case, we didn't do that. We just want to make it, kind of as succinct as possible, because if you want to, basically, if a doctor wants to add a chemotherapy regimen or start with chemo and then add some of these targeted agents, that's something that our providers that we work with do quite frequently. So they can start a chemo and then add, let's say, alectinib, or if they want to keep you on lorlatinib for whatever reason, because they're conservative, they can also add like lorlatinib, but we don't think that this is a good option specifically for your mutation, Linnea. So, okay, I guess one conclusion is that it's important to keep targeting ALK. It's more of a matter of what do you target with, because there can be resistance, and we're pretty sure there is. And what's going on right now is not working very well. So with that, you have to make sure that it's drugs that you'd still be sensitive to, given this particular mutation, given this profile. And then secondly, when somebody asks, okay, well, if there's no direct drug for a certain alteration, then how is it targeted then? So it's targeted indirectly, and in the case of TP53, okay, there's no drug that can fix TP53, but there are strategies that address TP53 indirectly based on what it does downstream. So once, or actually doesn't do, so if TP53 is malfunctional, then some of the things that happen downstream, which is hundreds of different pathways that can be turned on, some of the things are known to be clinically relevant and sensitized to good response to drugs that are against angiogenesis, like Avastin, which is bevacizumab, and also some that are receptor tyrosine kinase inhibitors that would target VEGF receptor, the receptor of the ligand VEGF-A, which is downstream of P53. So of all the things that happen downstream of P53, if there was one pathway that actually showed any kind of clinical sensitivity, that's the VEGF and VEGF receptor. VEGF receptor, I mean, it would be actually a lower scoring one. It can be targeted with cabozantinib, but bevacizumab is a monoclonal antibody, and it's easily obtainable. And all of these drugs, by the way, are on label and FDA approved for this specific cancer type. So in terms of just likelihood of getting the drug and likelihood of lesser sort of toxicity, lesser of all evils. So targeting TP53 indirectly would be bevacizumab, and then targeting ALK, there are these alternative drugs like brigetinib and alectinib that have really good IC50s, and that's all based on FDA pharma review that target ALK specifically with this alteration. So when you have this specific mutation, it makes you resistant to some, but still sensitive to other ALK inhibitors. So if, Linnea, if you could be switched to something else that's also approved for your cancer type, it would be basically alectinib or brigetinib, or if they want to keep you on lorlatinib, then it's a little bit lesser of a score. And then there is also a potential to consider ceritinib, and the only reason why this also came up here is because even though its IC50 is not so great, like the degree of how well it binds and inhibits ALK as the target, it actually also inhibits IGF receptor, which can also be downstream of P53. That is also because of the dual targeting, it also came up here, although the score is not as great. So the whole strategy is to keep targeting ALK, just do it with the right agent, plus indirectly target P53 with VEGF inhibitor Avastin, which is bevacizumab, and that's where the therapies, the top therapies that came up, that's where all the rationale is coming from. And there's references in case somebody wants to read about, what is the targeting profile, what is the justification for VEGF-A targeting via for P53. We have references on the last page. And
Ellie, can I ask you quickly, how do you?
I'm good. I'm done now. All the questions, please ask.
How do you come up with the score?
Well, that's our many years of the whole entire cure match technology development. It's a combination of years of manual expert curation from biochemistry, genetics, molecular biology, and to clinical practice, and combined with our algorithms that basically say how well is the current therapy regimen matching the given patient's tumor profile. So if, let's say, all of the alterations were completely, directly, confidently covered by this combination of drugs or a monotherapy, then it would be closer to 100%. It's like, how well are we addressing what's driving this particular cancer cell profile? And that's what the score represents, and I should have defined it.
Got it.
Ali, there are two comments in the chat which you should respond to. Emily, would you voice your comment?
Sure. So as far as I know, alectinib and brigatinib, and I think ceritinib as well, none of them cover the G1202R mutation of EML4 ALK. So I think lorlatinib is the only ALK inhibitor that actually is effective against G1202R.
I think that's correct, Emily.
Do you see my screen?
Yes.
This
Oh,
was-
maybe you need to change if we're still looking at the
Yes.
report. We still see the report.
It's okay, actually, I probably shouldn't show it. It's like a snapshot from our internal knowledge base. Basically, it's an FDA pharma review, so it's very easy to pull up the ones for alectinib and brigatinib, and those are the ones that have absolutely the best IC50 values. So unless we made the kind of similar mistake twice, and all the people who review each other's work during curation also made that mistake, I think that I should be able to resolve that one easily just by pulling the actual FDA pharma review literature. So alectinib and brigatinib followed by lorlatinib, and then ceritinib has a kind of a questionable IC50 for ALK, it's 120, but because it also targets IGF receptor, because of the dual targeting, it came up, and as you saw, it was as a lower score. Doesn't have to be necessarily the top choice, but our main goal is decision support. So we try to provide as much of the matching options for the given profile so that the doctors make the final decision, but it's our job to provide rationale, and it has to be rooted in all of the science and the references, so I can follow up with that.
Okay.
Linnea, let me just do a process check. We've got about 10 more minutes if we were to stop at an hour and be respectful of everyone's time. What is the best thing that you could have? What you said, I mean, you suggested that if we could establish a way to ask questions of Alice Shaw and Jess Lynn, that might work. Or we could prepare a report. We have this working document on your treatment options. What is the best product deliverable that we could give you and give to Jess and Alice? I mean, this report from Alice certainly falls in that category.
Yeah, I think starting with almost like a burning question forum might be a good place, because I think there'll be return for the participants as well. And it will also help quickly establish as far as what they would absolutely rule out, and that will save people time, because obviously they both have a lot of expertise, but also strong viewpoints, and just know my case very well because they've been with me for a long time, Alice in particular. But
So,
I think that would help me, because I'm, some people are natural note takers and then could transcribe easily these questions to them. I'm not so good at that. So if any of you have these burning questions, I think this might be a good way to approach it, because then I can take it to clinic or email them and they can respond directly.
okay, so what you're describing is we could do this on the Slack. I'm just trying to be very mechanical. Is this an email? So, I mean, this whole session right now, the recording is still on. I've recorded this, I can transcribe it. But I'm sort of, the question I have is, what should I extract? What's the most valuable thing that we could extract in this conversation with Alice Shaw and Jess Lynn?
Ricardo and Emily, what do you think? Because you're both patients of them. Hello?
I think
Yes.
I think you have to be like super summary with them, right? Because they're like, every doctor, like doing what Camage did, which is to like look at the videos, 20 minutes, like that's a lot. Like I was shocked that he actually did that, right?
Me too.
So
Me too.
I think that was very fortunate that he did that. We caught him at the right time. It was the right day. All those things aligned. I think you got to bring in summary what the three most important things that you would want to ask them. and that, or part of the report. I don't know if they're going to go deep into the cure match or Karis report. I think she has the Karis report.
She does.
Yeah.
If you look at our first page, like just this, that would be awesome. That's it.
Okay. Yeah.
Just this part. Like, can they give
Yeah.
the
No, they
and
would
either
definitely
electronic or
look
Bridget?
at that. Yeah.
That's about.
I'm a little confused about the fact that Linnea has been on these drugs and has resistance mutations against some of these ALK inhibitors. So I'm still confused why these would still be on the table unless we're giving like metronomic or rotating or baby doses simultaneously. I don't quite
Yeah,
understand.
I would agree with that. That
Me too.
doesn't.
So
Yeah.
lorlatinib is not something we would give, but we did not consider previous therapy. And that was my disclaimer I put when I shared it on Slack, that we did not consider previous therapy here because I didn't get all of the breakdown of past treatment history. This is just what known drugs molecularly match. This molecular profile, and with this mutation, actually IC50s vary whether it's wild type ALK versus this specific mutation, and we have different records in our knowledge base what those IC50s are. And with this specific mutation, particularly alectinib and brigatinib are the best matches. That's all. They're the best targeting agents that are available. If some of them were already attempted, our chief medical advisor, Razel Kurzrock, we talked about this case. She says that from what I can learn here, obviously what's given right now is not working. And, that should be probably considered, but most likely oncologists already are thinking that. So if they also want to rule out other things, that's fine. But these particular other drugs are specific to the given ALK mutation.
Ali, I was in trial for ceritinib, so I've done that. But I have been told that alectinib and brigatinib are not options for me. And it is because of that G1202R.
That's interesting. Okay, well, let's see if I can find something compelling that maybe will, make them reconsider at least for 5 minutes. But let's see.
Okay.
But bevacizumab is something that can be added, to other regimens easily.
I was just going to make the point, Ali, about maybe like I think the piece that we're missing here is the longitudinal trajectory of the mutation, right? So like, was it a translocation? Is it now just a point mutation in the gene? I'm myself am completely confused at the moment about that. So
yeah,
what I'm getting at is things that Linnea had tried before and they failed, or things that she's being considered not eligible for because of a specific mutation. Has something changed about her tumor now that it's progressed that might put these previously tried agents back on the table? Is there an argument for that? And I think you're trying to make the same, perhaps make that argument, right?
Well, I think they don't, for one reason or another, even though they are somewhat similar, they don't seem to have the same binding efficacy or inhibition efficacy for the same target based on different mutations. So of course, if there was a translocation, some things could have changed. But the ultimate, like the gestalt of it, is that we probably don't want to just stop inhibiting ALK, because that's one driver. If you basically don't take care of it, and let's say that trial with glutaminase, if they say that she has to be off the drugs, then unfortunately it's like you let ALK just overdrive and take over, and it won't even care that glutaminase is being inhibited, because there are other ways that ALK-driven tumors will still progress. And so that was another thing that Dr. Kurzrock, wanted to highlight when we talked, that you still have to target ALK. It's just which one. So of all of the, even if they're all evils, you pick the lesser of all evils. And if any of these have not been tried yet, these specific ones, then they should be tried. So we can't say ALK inhibitors have been tried, that's why all of them are now probably no good. They're not all equal. Not all ALK inhibitors inhibit with the same efficacy. So knowing exactly what alterations are there, I can rerun the report. We can recalculate it, no problem. But should we still consider ALK inhibitors? I think absolutely yes. And I'm not the only one. Our whole team thinks this way.
I
Oh,
think,
yeah, actually, I can. Kimmer, sorry, I just wanted to weigh in here, and sorry to say this. You're right. ALK should be targeted, and I think the presence of keep on, and which brings up my question: that is this biallelic loss of keep on? Is it really something? Is it under loss of heterozygosity? Is this something important we should even pay attention to? But keep on, in general, there has not been any breakthroughs in terms of targeting keep on. Usually does not appear in combination with ALK, so makes it another more suspicious that this is not necessarily a contributing factor to the progression of the disease. And the way we know this ALK positive tumors, there's no way to fathom that a glutamase inhibitor by itself is going to be stopping the progression of an ALK positive tumor. And Ali, every literature in the world just says that first and second generation ALK inhibitors, for this mutation are not effective. So, I mean, trying alectinib with bevacizumab, it's not going to change anything, as much because, bevacizumab is an effective anti-angiogenic drug, but alectinib itself, all the journals in the world, Alice Tisha has got plenty of journals out there that the IC50 for alectinib for this kind of mutation is pretty high and pretty ineffective in these kind of settings. So, I totally agree with what Linnea said, that potentially changing to chemotherapy to keep the disease at bay, and then enrolling in that TPX trial for ALK is unfortunately, I think, the best way or the only way to go. And I think that's the only way that makes sense. Any other thing would just be band-aid on cancer. Literally, glutamase inhibitors or alectinib is not things that can change the trajectory of this disease right now. So G1202R, I think, I was reading about TPX. I think there's some initial data. So, there's some encouraging data. So I think that's the only way to go. And I think at the moment, chemotherapy might be the best, modality to just, stop the progression of the disease. That's just my 2 cents, but sorry, guys.
Thank you.
To share that with you.
Thank you, Murad. Linnea, we don't have a process for, let's say we have 3 experts and 3 different opinions that we've heard. We don't have a method for integrating them. And you were saying, what are the questions we could ask Alice Shaw and Jess Lynn, because they will respond to questions. So it's almost like we want to frame our assertions in the form of questions. Like, what do you think of this option? What do you think of that option? What do you think of this option? So we could frame Murad's, Ali's, and Kimri's suggestions as, what do you think of A, B, and C? We've got 3 suggestions, and see how they respond that way. I'm just trying to close the conversation here. Again, being respectful of people's time. What do you think, Linnea? Would that be consistent with what you were suggesting as a process?
Yes, but I would also encourage anyone in the group, if they personally have a question or an idea or whatever, just want something confirmed or denied, to submit it. Because, even if I go to them with a list of 6 things, for instance, we can quickly go down those.
And I'm just going to get mechanical again. You want those to be emails to you? Do you want it to be on the Slack? What's the most effective way for you to integrate those into like something you can take and?
I think for me, the easiest way, given my technical impairment, would be if they are collated in an email, and then I can copy that and send them to them.
Okay.
Hey, Brad, what I would suggest is somebody creating a centralized Google Doc on the cloud, and then everybody has a timeline to have their questions, and then somebody that has a medical side will take a look and basically consolidate them, so she can just copy and paste.
It's there.
That would be great.
Yeah, so that's there. That shared Google Doc is there. It's called Linnea's treatment options. It needs to be updated based on this conversation. I'll take some effort, put some effort into that. But it's open source for you and everyone else to also contribute to. But what I hear, Linnea, just to play it back to you, is we should take whatever insights they are. And in the same way that Allie's report sort of had the top line was the bottom line, like, here are the 6 questions, then we can have a lot of other stuff, but here are the 6 questions or the 3 questions or what have you. Is that focusing on questions you can ask? Is that correct?
Yeah, or even if, just pretend you were sitting across from Jesslyn or Alice Shaw and wanted to say, I have this idea, I mean, they are actually very open to that. I just think that they're incredibly time constrained, and that's the reality of it. But yeah.
So we've talked a lot about treatment tonight, but there's still, at least on my mind, a couple of unanswered questions, even about your tissue and any outstanding tests. Is it true that all of your tissue is gone?
Yes. And I asked Jess, and she said a lot went to Karis. It was 4 blocks. And she did want to send them more because she was very interested in having the RNA done. But when she approached the lab, they said that it had, meaning at MGH, that it had been depleted.
Do we know what IHC tests MGH did in-house on your tissue, and whether or not there's even 1 slide left, 2 slides left to do?
I don't, and this would be a good time for me to reach out to my friend John Frady, and I'll see if he can answer. And then another promise I want to make to all of you is that I just have to confirm what my username and password is, so I don't give you the wrong one on Citizen, but I want to make sure you all have that too, because that's fun to play with.
That's particularly useful to someone like Allie, I think. Yeah.
So
Yes.
I want to clarify a couple of things then. So what my burning question is, I would love to know if you have LKB1 protein expression. Your STK11 was wild type. It was not mutated, but that doesn't mean it wasn't methylated. And KEAP1 and STK11 often go together in lung cancer. And if you have the lack of LKB1 and KEAP1 mutation, that doesn't bode well for immunotherapy or chemotherapy. So
Okay.
we're talking about chemotherapy as an option. I want to know if there's any implication of a chemotherapy resistance mechanism going on through
Right.
a STK11 KEAP1 code. Now this would be very, very rare, right? ALK KEAP1 STK11, but we already know you're a rare bird, so I'm not ruling anything out with you. That's my burning question, and it's an IHC question for John Iafredi.
All right.
Can he even restain an H&E slide if he has to, and do something to?
Okay.
To me, that's a big question. Then the second thing is, and I'm answering Allie's question in the chat. I want to be clear that I'm not really recommending a clinical trial. I'm recommending compassionate use, to use both an ALK inhibitor and something like a glutaminase or arginase inhibitor. A clinical trial is really going to restrict the ability to stop both pathways, right?
Yeah, exactly.
And I agree with both what Ali and Mehrad were saying, but I don't think we should count out KEAP1. We just don't know a lot about it yet, and it's still early days for KEAP1 as a target in lung cancer. And I'm more concerned about, can we do a little for both rather than everything for one pathway, right? And I think your doctors are going to have some ability to play around a little bit. And that's like, we didn't even get to the metformin conversation, okay? But that's another way they could play around with some of that, metabolic pathway stuff while on an.
I want to second that, what Kimry's saying. Second that if you can target multiple pathways concurrently, it also brings in the idea of possibly even the in chemotherapy, low dose chemotherapy or attenuated dosing in chemotherapy, which also has some implications for immunomodulation. I think that's important to consider. I'm not sure it would be in this translated into a question for discussion with the doctors tomorrow, but it's important to consider. And the idea, Kimry, what you said about compassionate use, I think, Brad, from the hackathon point of view, is in addition to making sure that there's clarity around HIPAA authorization, HIPAA information exchange, also how in a case where you want to have at least the option for compassionate use, how can that be automated or at least facilitated? What pieces of information, who needs to talk to whom, what signatures need to occur, how does the information need to be framed for the local physicians, because that's important to make that as quickly as possible.
Thank you.
Yeah, the paperwork, right? So having a little bit of a lead time on that. So like, for example, whether or not you're going to ultimately do it or not, it'd be great to start getting on the horn with Calathera and asking about, you know, I mean, usually it's your physician that does that on your behalf, right? But is there a way to just start calling, and can we start gathering information about that? I mean,
Yeah.
I could give them a call, just generically speaking, and start asking them about it. But ultimately, it's your doctor that has to sort of, you know,
Right.
sign that document. But
From given the constraints that the physicians usually have, that the more you can prepare, the more you can prepare and make the information in a summarized, ready to process format, the better. I've often had patients say, you know, essentially get yourself qualified for the trial, and then you can decide if you're going to accept or decline. Or if you all of a sudden want to get a trial going, it's not like starting an antibiotic, you know, having an infection in the afternoon and having an antibiotic that night. It takes sometimes weeks to get things up and running.
Right. And it will take a minimum of 5 weeks, I think, for compassionate use for TPX. And again, Jess wants to make sure our timing is right as far as dose.
But she should start filling out, I mean, can she get you qualified right now and then say, hey, you know what, guess what? I want to postpone this.
No, I think this is something she will go after. You know, I don't think they're just waiting for my cancer to suddenly appear again before they make decisions. I mean, they know it's there. They just can't quantify it right now.
That's what I'm getting at is are they going to fill out all the paperwork, get you qualified, and then wait until there's a dose and then get you on that program? Or are they going to wait till there's a dose and then start filling out the paperwork and get you on?
That's a good question, Kimry. I'm not sure how
and I guess
actually what the protocol is. So
what we're advocating for is to get you pre-approved.
Right.
Pull the trigger on it when they think the time is right. Because
one last thing, Linnea, and this is like in your hands, is on the integrative option that Willow Valley has talked about and Kimmery has talked about metformin. Like those are your calls. I mean, you can turn that on and off whenever you want. So like I'm not an expert on those, but you know, there's some data points that are intriguing there on targeting multiple networks. So you know, you don't need to, talk to Lynn about this one, or you don't need to talk to the world about this one. This is in your hands if you believe it or not.
Yeah, keep it out of that discussion, keep it focused. I believe if you ask about a number of things, some of them it's not even in their realm to decide, you know.
Read.
Okay, good.
Okay. Shall we wrap? Anybody got anything they want to say before we close? Okay.
I had one other thought, and that was that, with the binimetinib lorlatinib combination, there was, evidence of efficacy response there. And, unfortunately the retinal tox put an end to that. And MEK and ERK inhibitors in general just have really poor tolerability associated with them. And then in combination, it probably even decreases that therapeutic index even more. But looking at a possibility of a different MEK inhibitor or maybe a different ERK inhibitor could be another trial option. But going back to the points of cis versus trans, what mutations are really there? Really have to know that in order to know if having lorlatinib on board at that time is the best option versus any other ALK inhibitor, or are all ALK inhibitors resistant to the particular mutations in ALK that Linnea's tumors have at this moment. So, and with the data might not even be there. With NGS, we may not know if they're on the same allele or not, if there's double mutants being seen. So anyways.
Was that Lars? Was that Lars speaking?
Yeah, sorry.
Thank you.
Yeah, I had to pop off I had to get in the car. So I transferred to my phone.
I was just seeing the number, and I thought that sounds like Lars, but I wasn't sure. Okay, thank you.
I think they report the allele fraction. Usually it's in the report. They don't do like heterozygous or homozygous. It's just how many reads you got from the entire cancer population sample out of total.
Right.
Okay. Anything else? Okay. Thanks very much, everyone, for taking the time on a Sunday. We'll start working on reflecting this important conversation in a document that Linnea can take to Jesslyn and Elisha. Thank you very much.
Thank you all.
Thank you. Thanks for
Nice to
Thank you, guys.
see you again.
Nice to see you, Linnea.
Thank you.